These two very highly estimated anesthetists, it will be interesting to hear the surgeon's view. So I'm happy to introduce to you a Belgian surgeon, Dr. Luc Otruyve, who is also the treasurer of our international association. Welcome, Luc.
So thank you very much, Mr. Chairman, for the kind invitation to have the occasion to speak for this audience at the 10th International Congress of Ambulatory Surgery. I'm coming from Belgium, I'm a surgeon, and I'm also the president of the Belgian Association of Ambulatory Surgery. So my question is, for this audience, my question is the longest surgical pathway also the best pathway? When you are since long time involved in ambulatory surgery, as we all are, so I think everyone has his own manner to do some things. And for me, the longest way means the clinical course set out in which all the rules and all the regulations have been applied as they should. So until today, I don't think that there are really legal obligations to do things before day surgery and before day operations and treatment of the patient. So when I say that, then I mean the full clinical pathway is applied, which means that the patient, first of all, is seen by the surgeon. He is referred by the general practitioner to the surgeon. That in agreement with the patient, decision to surgery is made, and that with the surgeon and between the surgeon and the patient, the appointment is made with an anesthetist to check patient's readiness to be safely operated upon. So I think that could be the pathway. That is the pathway what also already has been said this morning, to prepare your patient to do safe surgery and to give a good operation to your patient. This means also that the anesthetist has to check whether full blood count, chest X-ray, ECG, and if all these things are necessary or not. If it's necessary to do extra examinations before the operation. So then we have also the question, what about respiratory or lung checkup? What about endocrine checkup for diabetes patients? What about extra pediatric advice? Can we give this to the anesthetist? Because I think you can do that, but is it necessary to have more specified or more specialized advice before surgery? When I heard the words of Dr. McWhinney, then his typical surgical pathway was a pathway what is creating also a long waiting list, because you have to follow all these rules, what I'm now saying. Once all these necessary preoperative examinations done, at that moment, we can only start with planning our operation. So if I see my patient today, I don't think it will be possible to see an anesthetist or someone or other specialist to see that patient in the following days to prepare them for an operation. And I don't know if I can plan my operation even when there is no waiting list, if I can plan my operation already for the next week or in the next 2 weeks. So when everything is okay, when your anesthetist or when your other specialist give green light for the operation, then you can plan your operation, or you go to your day hospital for the planning, or you go back to the surgeon with your paper and you say to the surgeon, okay, I'm fit for operation, I can be operated upon, so I have to make a new appointment, a new contact with our surgeon, with your surgeon. So what's my question in this? But before I will say something other, in Belgium, for example, the preoperative examination by an anesthetist is not an obligation, but there is a fee for that. So if anesthetists are interested in doing preoperative assessments for day surgery patients, they can do that. They can have a fee for that. So this is one of the possibilities. But what I now want to say is, surgeons' kindness and natural way of doing things seems to disappear. So I have the impression that when you have to follow all these rules, all these obligations, then I think a surgeon who takes his job seriously, who has a clinical eye on his patients, he can see if his patient is fit to undergo the operation he has in mind. In this case, it should be very well possible to plan with your patient an operation without having to go through all these routine preoperative checkups. Okay, I'm here to have the discussion, but indeed, not everything can be covered with even a maximum of precautions. And even going through the fully comprehensive checkups, there is still a risk of problems. There will always be a risk of problems. So, for example, when I heard from the previous speakers that a one-stop option is possible, I think a one-stop, you can see your patient at the day of the operation. You see him for the first time, you decide that there has something to do as a little operation, and at that moment you can decide to do this operation. When you have time to do that on the same day, you can do it on the same day. Because in Belgium, that's the reason why I say that, we have no waiting lists. We can plan our operation in the following days. So we lose time preparing our patient and asking for preoperative assessments. I don't agree with the telephone pre-assessment because I think you have to see your patient. That's just something that I had to say. In any way, not everything can be covered with even a maximum of precautions, and even going through the fully comprehensive checkups, there is still a risk of problems. So my question is there an evidence-based reason to do so, to do this preoperative assessment in the way we explained all this today and this morning? Is there a legal obligation? And if there is one, then do we follow this? If there is no one, then I think it's up to us, to the surgeons or to people involved in ambulatory surgery, to make rules that are easily to use in favor of the patient. Because it's a fact that, as in the summary of Dr. Lip has been said, the patient has to be operated, has to be helped. The most important is that your patient is good and is satisfied when he has got his operation. So I advocate the surgeons are also trained to establish whether or not the patient is fit to undergo. And perhaps there are specialties or there are surgeons who are not trained to do that, or who are not interested in the good of their patient, and who are just only interested in operating and operating and operating. And that's, I'm totally and agree with you if you would say that to me. But I think when the surgeons are trained to establish whether or not the patient is fit to undergo the surgery, of which they are fully aware of its length and seriousness, so let surgeons be there when decisions are made. That is the message I want to say to you. In any way, please don't give us oversized organizations to organize our operations. The patient is coming for a day surgery, for a short treatment, and not for being involved in a whole circle of pre-assessment examinations. That's what I want to say, but I'm not so dangerous that I will go into the discussion. Thank you very much for your attention.
Thank you very much, Luc. That ought to be a good base for a good discussion. So let us hear comments from the floor. And yes, please. Any comments, questions from the floor? Could we have light so we can see what's happening? Yes?
I'm very interested in hearing the surgeon talk to the patient about the home situation, whether they have a carer at home and how they get home and how they're going to manage on the days after the operation.
What was the question?
All right. I'll tell you, the question is that as a surgeon, do you discuss the other things that they do in pre-op assessment? So about, do they have a carer at home? What are their social circumstances?
But yes, I'm also since years involved in ambulatory surgery. So caring at home, pre-operative assessment, I think everything is important. It has to be organized, that's right. So you have to have your carer at home, for example, by nurses or by the care family or something like this. It has to be organized, that's right. But the only thing I want to say is let us don't oversize all the organization. That's what I want to. Is that an answer on your question? I don't know. Thank you.
There was another question from the floor, I think. Yes? In the back.
Yes. Thank you. My question to you was regarding the phone calls pre-assessment. Is that the pre-assessment that's referring to a medical pre-assessment or the nursing pre-assessment?
Well, it's the nursing pre-assessment, and that would indicate whether the patient needed a medical assessment. We would try and select patients for telephone assessment that we felt were very unlikely to need any medical input. So we currently choose people who are under 45 with no medical problems, not taking any medication. I think in many other hospitals, they have much wider criteria, and they would take much older patients and still do them as a telephone assessment. And if anything comes up from the telephone assessment that would indicate they need to be seen by a medical person, then that would be arranged.
Thank you.
Do anyone have experience with another electronic assessment with the patient at home, telemedicine, video assessment? Do anyone have any experience with that? Any of you?
I don't have personal experience of it, but I've seen it demonstrated from somebody in the States, where I think it's quite commonly done.
Well, I know that there are hospitals close to me that are using telemedicine and starting, but the issue is that it's trying to get the standard of the link. So what they're using is telemedicine in a nursing home or in a local library, or so trying to provide a facility that the patients can go to, because there's a huge difference between Skyping someone and actually trying to have a good conversation over a telelink and actually being able to visibly see the patient and get an assessment of their functionality and everything as they're there.
And that's also my point of view. You can have all this information by mailing or by Skyping or like that, but you have to see your patient. As a surgeon, you have to see your patient, and we have the checklist that the patient has seen his surgeon before the operation. That's because the contact between the patient and the surgeon is so important.
But it could also be a question about saving some of the surgeon's time. If you could use some other's time to do some of the investigation. So to utilize the surgeon best possible is to use him in the operating theater, I think.
Okay, that's right.
Yes?
In Australia, there is some software being designed and trialled where patients it's web-based, they can go in and answer quite comprehensive questions, which will then come through into the iPhone or iPad or equivalent of the anaesthetist. And then from there, the anaesthetist can have a look while they're in another session or whatever they're doing. And that can also, the hope with that is that the anaesthetist is going to get more information than just on the day of surgery if it's been pre-admission by a nurse only. And then a comment to Luke about pre-admission. In Australia, the surgeons do still see all their patients face to face, not a problem, and the consent is between the surgeon and the patient. But more and more the nurses are bringing in another element of pre-admission assessment, and then, as is with the UK, then moving on to an anaesthetist if required, or any other allied health in fact. So surgeon, yes, always sees them pre-admission, but we are using nurses more and more to assist with right patient, right criteria, right everything else.
Was that no question?
No, it was just
Thank you, it was no question. Thank you.
I was wondering what it takes for you to cancel a patient after the pre-assessment, because we all want to avoid the gap time that you talked about earlier. Because sometimes in our unit they turn it from outpatient to inpatients, for instance, just to get through with the program.
Should I ask? Yeah. I think that's a very good point. My premise is that if a patient's not fit for an operation, they're not fit for it as a day case or an inpatient. So it's rarely making it any safer to move a patient that was considered as a day case to an inpatient to make it happen. The sort of things I'm thinking about is if the patient turns up and they've got a chest infection they've recently developed, they're not fit to have it done whether they stay or not. I think the only things that I would consider changing the patient's admission from day case to inpatient are things where spending the night in hospital is going to make it safer or more comfortable, and that should have been identified at pre-assessment. I can't think of many things that are going to crop up between the pre-assessment and admission that we wouldn't pick up that would mean changing them to an inpatient makes it better. The only thing we commonly might come across is somebody's social situation. When we first assessed them, they said, oh yeah, I've got somebody. On the day, they say, well, actually, no, I haven't. And I think that's is a dilemma, and I think this is one of the things we ought to be thinking about more carefully. How essential is it for somebody to have a carer physically in their home that night if they're having perhaps something relatively minor done, and they've got somebody readily available on the telephone? I think to cancel them or make them stay in hospital for the night is just encouraging them to lie, basically, about whether they've got somebody there or not. I think that's what many people will do. They'll just say, yes, I have, so they don't get cancelled.
There's a question in the back.
Hi. I've got a comment and a question at the same time. The comment is regarding the pre-assessment, and especially the telephone pre-assessment. As a trainee myself, I have come across some cases where the patients were telephone pre-assessed and it was thought to be fine, and when the patients came, whether they were, for example, the patients I came across they were over 60 or 70 and fit for their age, but they didn't have an ECG, and then were rushing the morning of the surgery trying to do that. So again, I'm a bit suspicious myself about the role of telephone pre-assessment. But my question is, after Dr. Luke's presentation, sometimes I feel we do things out of caution. So for example, patients who are coming for day case laparoscopic cholecystectomy, I see the reason for doing a liver function test in the pre-assessment. But patients coming for hernia, if they are fit and healthy, let's say in their 30s or 40s, do we need to do a full blood count and things like that? Or could that possibly be omitted?
No, that's not necessary, I think, but that's the problem. I think we have to have some rules and some but the most is when you see your patient and he is fit, then there is no problem to do that. I don't think that's really necessary. Don't you think?
We have NICE guidelines, National Institute for Clinical Excellence, that we follow, and they are very conservative about the number of investigations that need to be done, and so it's much less of an issue